Welcome to the Exhale podcast, a candid conversation about current matters relating to respiratory diagnostic and lung health. Today's hosts are Mark Russell, Marketing Communications Manager, and Troy Prejean, Executive Vice President of Sales and Operations for Vitalgrath in North America, a global leader in respiratory diagnostics. Troy and Mark had a delightful conversation with Dr. Kirk Hinkley and Matt Pavlichko, a respiratory therapist for Vapotherm. We discussed their high-velocity therapy and how it saved lives during the pandemic and continues to be an alternative method for patients who are mask intolerant.
Well, welcome, Kirk and Matt, to our podcast.
Thank you for having us.
Thank you. Well, please give us your background on yourselves, education, experience, and what your current responsibilities are.
Yeah, so I'm Dr. Kirk Hinkley, and I have my colleague here, Matt Pavlichko. I am the Director of Education at Vapotherm. I'm also a board-certified emergency physician and EMS physician. I've been in medical directors, emergency departments prior to joining Vapotherm. I'm also currently full-time practicing physician as well, which I think is important because I still use all the technologies that you guys are going to talk about. My background, I did my medical school training at the Penn State College of Medicine in Hershey, Pennsylvania. And followed that on with an Air Force-sponsored emergency medicine residency through Wright Patterson Air Force Base and Wright State University. From there, I spent some time in the Air Force where I flew as a critical care air transport team physician and lead prior to getting out and going back to the civilian world. And Matt?
I'm Matt Pavlichko. I'm a respiratory therapist by trade and a hospital administrator. And I've been with Vapotherm for about a year. I work with Kirk in medical affairs, and I also do a lot of education. Kirk kind of takes care of the physician aspect of our company, and I take care of the respiratory therapy aspect. I have degrees in respiratory therapy, healthcare leadership, and training and development. I've been a respiratory therapist for 25 years, but the majority of it was spent as a hospital administrator, a respiratory director. I also am the president of the Pennsylvania Society for Respiratory Care and a big advocate for respiratory therapists. So that's kind of my background.
Well, we love it. We love to have that kind of expertise on the show. And interesting to hear that you were in the Air Force. Actually started out in sleep diagnostics myself down at Lackland Air Force Base. Wasn't in the Air Force, but as a civilian. So we probably stomped some of the same ground together at one term or another. So to start off, though, what is Vapotherm, high velocity therapy, and how does that really help you rethink the traditional approach to respiratory support with patients?
I think of Vapotherm as kind of the new way to do non-invasive ventilation. And even though it's really not that new, I mean, Vapotherm as a company has been around since right around 2000. And so it's technology that therapists have seen for decades now. And what we're seeing, especially now after COVID, is that these nasal cannula-based therapies, and ours in particular, has really taken off because of the tragedy of COVID, right? So prior to that, I was one of the fortunate ones that had this therapy in my department, got to know it and use it and love it, treating all types of respiratory distress, right? So a lot of people think of our therapy and other high-flow nasal cannulas as only treatments for hypoxic respiratory failure. But long before COVID, I learned that this could be used for all types of patients, right? Whether they be your hypercarbic COPDers, your congestive heart failure patients, even some patients that you might not think of as good candidates for these therapies, like some of my septic or shocky patients, right? So been using it for a long time, been pretty aggressive user of the therapy prior to Vapotherm learning my story and reaching out to me. And like I said, I think this is the way that we do non-invasive ventilation in a comfortable way, like with a focus on relieving suffering rather than purely providing a copious amount of oxygen.
For me, Vapotherm was my savior during COVID. I was a consumer of Vapotherm products during COVID. And what it did is it helped me keep patients off ventilators, because during COVID, if you went on a ventilator, you died. And we couldn't have that. So for me, I look at Vapotherm as a wonderful device for all types of respiratory failure, and it buys me time to actually figure out what's going on. You look short of breath, I'm going to put you on Vapotherm, and then I'm going to figure out what the problem is. So that's just my 2 cents. But Kirk said,
yeah, I mean, I think it's always been the easy button of treating patients with increased work of breathing for me, right? So it was never, make sure that this patient has a hypoxic failure and then go ahead and put them on the high velocity therapy. It was never that question. It was always presented to me as, do you have a patient with respiratory distress? Put them on this therapy and then figure it out. And which is kind of what I do. I take care of undifferentiated patients that come through either the doors of the emergency department or through the ambulance bay. They often don't come with a note posted to their shirt giving me their diagnosis. And so I have to stabilize them in some way while I figure out the appropriate treatment for their condition.
Great. Can you list some of the advantages for your patients in using your system?
Yeah, so I mentioned that this is the way that I do non-invasive ventilation, right? So I think of the advantages in comparison to the alternative, right? So what's the alternative? And that's the mask, whether it be a BiPAP or CPAP. And I think the answer is obvious. You know, when I see a room of people, when I present to a room of clinicians, there's very few of them that have either tried on a CPAP mask or want to, right? And so the big advantage is, hey, this is not something that's cumbersome to fit to your patient. This is not something that takes a ton of therapist time. This is something that's easily started, could be up and running in just a few minutes, and that the benefits to the patient are immediately noticeable, right? So that air hunger that comes along with whatever is causing their issue is almost immediately remedied, right? So you see effect almost immediately. Not only that, but they can respond to me as their clinician, right? So they can tell me, oh yeah, I'm doing better. They can tell me they're hungry. They tell me they need to go to the bathroom. They can tell me they have some other symptoms, or they can give me the back history of how they ended up there. They can interact with their families. They can walk out to the bathroom. They can eat their breakfast or take their oral medications, right? I don't have to worry about somebody vomiting into a mask. And I don't have to worry about their developing pressure sores on their face, right? So oftentimes these people stay on these therapies for days on end. And so they don't need to be cycled between different size masks. They don't have to have their beard shaved or otherwise have these masks fitted to their head, strapped to their head in whatever way. I would say patient comfort, patient satisfaction is a huge driver, but for me, it makes my job easier as well.
And Kirk, you do this better than I do. It just looks like a nasal cannula. That's what it is. But since it's a podcast, you want to describe it as much as possible to paint that picture. Describe like what is small bore, what is the nasal cannula, and how does it actually ventilate?
Yeah, I mean, that's the big differentiator between us and what you would consider a high flow nasal cannula. Like most people think of Vapotherm as a high flow cannula, right? High flow oxygen. There's many different names given to it. And what I would tell you is that this therapy is high flow nasal cannula plus, right? So we carry an FDA indication that's totally separate from any other high flow cannula. And that's the reason behind that is the way that we deliver our gas. So we use a tapered cannula that generates high velocity, high kinetic energies, which is able to clear the upper respiratory dead space between breaths in a really rapid and efficient way. And so by doing that, it makes every breath more efficient. If you think of every breath that you exhale from the level of the cords out, that is getting replaced before you take your next breath. And by doing that, you get ventilatory benefit. And that's really the driver of why the FDA has given us a separate indication. It's why we have indications for hypercapnic failure for your COPD patients. It's why we can treat metabolic acidoses and other things. We can support the respiratory distress of those patients, help rectify the reasons behind increased work of breathing, maybe even if they don't have a direct pulmonary respiratory source.
I think that's a big point. So, Kirk, you do a great job explaining this. When you think about a pressure-based therapy like non-invasive positive pressure ventilation, you're actually moving tidal volume. You're applying pressure into the lungs to make your breath. This is flushing dead space. So it's actually truly alveolar ventilation. So you get the same effect in CO2 management as you do with a non-invasive positive pressure without the pressure. And it's comfortable. As a consumer, it was a great device for me. It was an awesome device, and mostly because they could eat, they could drink, and they could talk to their families. And those things really matter. And they're very hard to do with traditional pressure-based therapies that are out there today.
Yeah, well, as a former sleep tech, I can certainly relate to that. We would have endless trouble, not so much with the CPAP therapy, but with the mask compliance. And like you said, the pressure sores were a constant issue. Going to a full face mask was an issue. should they ever, trap air or start to become sick and vomit into the mask. So all of those things are very familiar territory to me. One of the things I noticed on your site that stood out, because it was a particular cohort that we would have trouble with in the titration of, CPAP, BiPAP, were pediatrics. How is Vapotherm better specifically for pediatric patients? It seems intuitive, but maybe you could enlighten us a bit.
I'm going to give you a personal story on this, because as a director of emergency department, I was at basically a woman and children's hospital. And outside of a big academic children's hospital, non-invasive positive pressure is just not really an option. Okay. And so that left us in a situation where our nearest PICU is an hour and a half away. And these kids are getting transported all the time for things that we could easily treat if we had a modality that was a little bit simpler and a little bit better tolerated by these kids. And so when they brought me this Vapotherm high velocity cannula, it changed our world in terms of managing our peds kids. All of a sudden, now we could keep these kids in-house. All of a sudden, our pediatric hospitalists were comfortable in caring for these kids because it's just a cannula. It's just a cannula. Now, we also had level 3 NICU there. And so one of the deciding factors when our facility decided to go to Vapotherm specifically was that our NICU docs jumped on board, were able to replace some of their bubble CPAPs and other ways of supporting their neonates, and kind of did so with both feet, right? So they jumped in. The next thing you know, we've pretty much replaced 80 to 90% of our non-invasive positive pressure. The big advantage to us, and this is a problem that we have that's not unique to where I practice, but we board a lot of critical care patient, like somebody bound for the ICU or somebody bound for a medical step down. Those patients often hung out in our emergency departments for days. And there's nothing that an emergency department nurse hates more than taking care of an admitted patient. It's not fair to them. It's not something that they enjoy. And it's something that certainly hurts nurse retention. And so helping to get that patient flow out of the department was critically important to us. And that included our pediatric patients. Those patients, instead of hanging out and waiting for a specialty care transport team to take them to the PICU an hour and a half away, now we could mobilize them, get them up to the peds floor. Our adult patients, instead of going to ICU or step down, we're going out to the med surg floors. It's just a simpler therapy, and it's really darn effective. And it's so darn effective, and it's so darn simple that if you haven't seen it, it's like almost hard to believe. In that regard, I think our users through COVID have learned a lot about it. But again, they haven't really learned the breadth of the acuity that they can take care of with it.
I would agree. And one of the things, you and I share this, Kirk, have you ever put BiPAP on a kid?
Never. No.
I have. It's excruciating. The kids feel bad. You're trying to strap a mask to their face. The mom is upset. It's just a nightmare. And I ran a children's hospital for a while, and I've done it many, many times. It is horrific to do. And I didn't have this technology at my children's hospital, but I wish I did, because I could have prevented a lot of that heartache.
I guess I have to retract what I said. I haven't taken care of a kid on non-invasive positive pressure in a long time. And I would say that that probably goes back to when I was working at Dayton Children's, right, as a resident. And so there, yeah, it was common. You get the tertiary care referrals, but it really takes that kind of level of facility to take care of those kids. You need somebody, like oftentimes they get sedated. Oftentimes, they have to be set up with therapists that are really geared in on taking care of those patients. With high velocity therapy cannula, the nurses can take care of them with some direction from the therapist, right? It's way, way easier.
And you're a doc, you'd have to write an order for that. Imagine you're in your emergency room, you have a respiratory distressed kid, and you're going to have to write an order for BiPAP. That would probably be miserable for you to know what you have to do because you don't have that type of technology. I mean, that's got to be challenging as a doc.
The other thing is we were intubating a lot of kids that we didn't want to, like let's say our asthmatics, right? We know that that's going to make the care of that child so much more challenging going forward if we intubate that kid. We know that positive pressure is not going to be good for that kid. We know that that's going to open them up to all kinds of morbidity. And so, yeah, we were probably intubating kids prior to having this Vapotherm cannula that, we're causing harm when it didn't need to be done.
So this system really can help patients with respiratory conditions to avoid this intubation. Is that right?
Yeah, so this is something that they use from 500-gram neonates all the way up to the largest adults to keep people off vents, right? So it is non-invasive ventilation. It is respiratory support for any patient with work or breathing issues. And so, yeah, I mean, what we saw is our NICU vent days went way down. Our non-invasive positive pressure admits that we're going way down, like, because those patients were destined to our ICUs and step downs. And so those patients which otherwise had no comorbidities that would land them in the ICU now could be taken care of on the floor. And so that really helped the flow through our hospital.
I was a consumer of Vapotherm, and when I think about, and it was through COVID, at the beginning of COVID, across the country, across the world, we intubated everybody and they died. When we started to figure out how to keep patients off ventilators and actually keeping them off, increase their ability to survive, we started to recognize something else. Because during COVID, we ran out of ICU beds, we ran out of respiratory therapists, we ran out of doctors, we ran out of nurses, we ran out of everything. So we had to figure out how to manage patients differently. And I could tell you a story that during COVID, during the height of COVID, very, very busy hospital I worked at, I had most of my Vapotherm patients outside of the ICU being managed perfectly. So when you are running out and you're running out of resources right now in respiratory and all of healthcare, we're running out of resources. So to use your resources to the best of their ability, that's fantastic. So think about a patient that can be managed with respiratory distress on the floor. My very first patient on the floor that I had on Vapotherm was on for 27 days.
Yeah.
And if we intubated him, he would have died on day one.
No doubt. Yeah. Yeah. And so there's a couple of points there. So when I started working with Vapotherm, I'm from a smaller place in Pennsylvania, and I work at the rural hospital close to my home to stay current clinically. And fortunate to have Vapotherm there before I ever arrived, but we have a co-located skilled nursing facility. And a nurse from that skilled nursing facility brought a patient down to the emergency department with respiratory distress. And I can't remember what the diagnosis was at the time, but think of your typical nursing home patient struggling to breathe. That nurse set the Vapotherm up. So this is a SNF nurse set the Vapotherm up on my very first Vapotherm patient at my current hospital. And I was just kind of blown away. Like, geez, I mean, I'm a doc. Maybe I should learn how to do this, and so from that time going forward, yeah, I mean, it's so simple that even a simple ER doc can do it. So, like our legacy system, our precision flow system is one button, 3 settings, right? So you're talking about flow, which is therapy, the FiO2, which is adjusted independently, and then a temperature, which is most often set to at or about body temperature, right? So right around 37 degrees. And like one button to do it. I really saw how simple it was when I have this lady who's a rather chatty Kathy that comes in not infrequently because she forgets to take her meds or decides to smoke a couple more packs of cigarettes or whatever it is. And she calls the machine the Hurricane. And she says, give me the Hurricane. I need the Hurricane. And she likes to talk so much that she actually hits the button, turns it down, says her piece, hits the button and turns it back up. And I know I'm telling this to Matt, who's a respiratory therapist, and he's probably losing his mind over the patient adjusting their therapy, but it's that simple, and the effect of it is that dramatic. And I can tell you that chatty Kathy never wants to go back on the mask again. And not only these patients are often do not intubate, but most of them are like, don't give me that damn mask, right?
Well, I can certainly relate to that. Given the choice of intubation or high flow therapy, I'm definitely picking the latter.
Yeah.
I suppose if there's any positive that came out of COVID, it was the innovations, and we certainly saw them from this end as well. People were put into corners that they never expected to be in, and like you said, a lot of patients are probably alive today because of those innovations
So it's funny, Mark. I go back. So at the time that COVID really became a big thing in New York City and basically our world shut down, myself and my boss were out at what's called the NAMDARC meeting in Scottsdale. NAMDARC is the National Association of Medical Directors for Respiratory Care. So it's basically the gray hairs in pulmonology that dictate how we take care of all patients with respiratory illness. And these are like the heavy hitters from all over the country. And people were getting put on these positive pressure death machines and not doing well, right? You remember in New York City, they get intubated and soon thereafter they were going out in a refrigerated truck. Mm-hmm. And they basically said to us, how can you help? And we really mobilized resources. We wrote like 3 papers on safety and efficacy for COVID and aerosolization and all that in terms of protecting our respiratory colleagues and the nurses taking care of these patients. And we were able to change the game. And I don't know if people realize it or not, but like one day everybody was dying in New York City with COVID, and the next day they weren't. And the reason for that was some education, and it was also a massive deployment of our technology into New York City. And I often want, I don't understand the Wall Street game too well, but I know that, boy, we really, really changed the game. We saved a lot of lives beginning in New York City. And fortunately, we're able to get that information, that knowledge out and shared through elements like this, through podcasting and online educations that were happening in a ad hoc fashion during COVID there. So we're really fortunate to have people like you out there, spreading the good word on this type of technology.
Yeah, I would be remiss if I didn't say thank you to Mike and Bernadette in their work in New York City.
Yeah.
Like, huge shout out to them. They work here at Vapotherm, but they lived at the hospital and helped out, and a lot of lives were saved from 2 really great people.
Yeah, no, we remember those days as well. There was a point where we were getting inquiries as to whether you could put a spirometry bacterial viral filter onto a ventilator, which was an unprecedented question. The answer was, I have no idea. No one's ever tried. So it was a very desperate time, and it really is interesting to see how far we've come since then. And guys, we've really been a pleasure to have you here to talk about these things. So where can clinicians go to find out more about this therapy?
So we have a really good website, and we have actually an education academy that goes along with that. So vapotherm.com, www.vapotherm.com. And if you click on the Vapotherm Academy, you can actually earn free CEUs if you're a respiratory therapist. We have a ton of knowledge, be it related to taking care of neonates to all the way to taking care of adults. We talk about some of our work of breathing initiatives. We talk about treating hypercapnia. We talk about leadership. Mm-hmm. We have the RT podcast called RT Sidebar, which is led by Matt and his colleagues. So we're really focused on education and getting the word out.
I look at, and Kirk and I really believe in education. Education is the knowledge that goes into someone's brain. And here at Vapotherm, we take that very, very seriously. And we're here to make and support respiratory therapists, nurses, and doctors to be the very best that they can be. And getting webinars and Vapotherm Academy and RT Sidebar are our pens, and that's what we do.
Yeah, we have links on there as well to our Med Affairs team. We're supported by docs like myself, with therapists like Matt. We have nurse educator, we have neonatology. Pretty much we run the gamut in terms of supporting our customers clinically. We also have an independent investigator program. So any researchers out there that are interested in using our technology, we do support that as well. And you can find that information on the website.
Yeah, you guys, you hit the nail on the head when COVID came in. We did the same thing with webinars and then, of course, this podcast. Education is a key. We developed a website called SpiroTutor, and it not only helps people access a lot of education about our products 24/7. And before, it was in-service, one-on-one kind of training. And now that COVID has thrown us into this, we developed that website. And we also do the same thing. We have, with the turnover of lots of personnel in doctors' offices, pulmonologists, asthma allergy doctors, a lot of these technicians are doing spirometry and they don't know anything about it. So we have a spirometry concepts on our training site where you can access and get credits to your licensing, especially if you're a respiratory therapist. This has been great. Anything else you guys want to add?
So kind of with respect to the roots of your company and treating black lung and miners and whatnot, I'm from Scranton, Pennsylvania. That's coal country if you didn't know. So one of the things I wanted to share is kind of a plug for my upcoming webinar this coming Tuesday. I'm going to be doing a live webinar, and it's going to be really focused on the canary in the coal mine and what we think the respiratory rate is really a predictor of badness and a mortality, and how that canary in the coal mine, right? So if you don't know the analogy, the miners used to take canaries down into the coal mines to see if it, to warn them of carbon monoxide down in the mines. We want to point out that the respiratory rate is often forgotten and can really predict badness. And so that's going to be one of the focus of my webinar with regard to using our therapy to treat work of breathing.
And Matt, I don't know when this podcast is going to get posted, but I'm sure it's going to be recorded and they can access that to your website.
Yeah, of course. It'll be available on the website shortly thereafter, and probably CEs will be given through the Vapotherm Academy related to that as well.
Wonderful. Well, guys, thanks so much for being on our program.
Yeah, we appreciate it.
We appreciate it.
All right, you guys have a good day.
You've reached the end of another episode of the Exhale podcast. Don't forget to follow us for upcoming new episodes and recommend this podcast to friends and family. Thank you for listening, and we look forward to you joining us again on the Exhale podcast, brought to you by Telegraph.